started. So, welcome to the One Human Nation show. And as we get started on today's show, it's kind of well, all the shows are close to my heart, but this particular one is really impacted by things that I'm seeing on the political level, as well as my personal experience as far as what I'm experiencing going through the health system that we're in. Not necessarily bad things, but observations that have kind of led me to the topic of today's show, which I've talked about before, and that is how much of a role is implicit bias involved in decisions that we see at the political level as well as at the medical level. So let me expound on that a little bit more. I think the hot topic trending this week, as far as some of the politics, is a bill that did not get through Congress because of, according to political lines, and one group is identified as being anti-infanticide, and the other group being, very much pro-life. I don't get into the politics of the. I think that's part of the issue in this country, as far as the silos that have been created. It's like if you're identify with one political party, it's assumed that you are totally to the left. If you identify with another, you're totally to the right. And to me, it's a deeper conversation of, how much of our decisions are made based on things we really don't think about, things that are part of our social construct that rolls into whatever roles we're playing, whether it's, and I don't mean playing in a good sense or playing loosely, I mean our responsibilities, whether that's in a political setting or whether that's in a medical setting. And so one of the things that, I've learned going through this health journey initiative is your attitude that you have when you're meeting with your healthcare practitioners has a huge impact in the type of care that you're going to receive. And a lot of that comes down to communication. Part of that does come down to what is the bias of your team, implicit bias of your team. Is there a bias that you may not even be thinking that that's what it is? You just may feel uncomfortable. And some of the decisions that I see in the political world, I sometimes wonder, is it really more than a political party situation? Is it more of we really, everybody needs to take a step back and look at what kind of bias am I bringing to the table, whether it's on a committee I serve on, and then if it's you individually, then, the role that you may play in your church or in the community or involved with the school district. I think that if we don't take a close look, it's very easy to throw stones and say, well, this person is a racist or that person is a racist. And that may be true, but is it really solving the problem? Is it really getting to the deeper issue of how do we overcome this type of attitude? So what I wanted to do on today's show is I was fortunate enough to find a video clip where this doctor, her name is Dr. Cooper, is giving a lecture. And she's specifically talking about the conditions for health disparities that exist in the United States between whites and persons of color. And she really goes into examining the roles of patient-physician communication, racial concordance in the patient-physician relationship, patient trust, clinician bias. I mean, she really does a deep dive. And this was a lecture that was produced in May 2011. And as we take a listen to this, if you or anybody you know are going through health issues, it may give you something more to think about, to really think about how is implicit bias having a role in the type of health care that you're receiving or someone that you know receiving, and what can you do to make a change. And it may be that you need to change who your physician is, but to recognize at a deeper level what the issue is, and to see maybe that there is something that you're doing or saying that's triggering this experience that you may not even be aware of. And I think the important part is the communication and the personal awareness. So let's take a listen to this particular lecture that really takes a closer look at how within the healthcare structure that disparities take place based on implicit bias.
So good afternoon, everyone. I would like to start by reminding everyone that after the talk today, there will be a relate and work with each other to achieve better care. It is my honor to introduce Dr. Cooper.
Thank you so much for that warm introduction, and it's great to be here today. We could be outside in the 70-degree weather, I realize. So I'd like to start out with an overview of the lecture. First, I will spend just a short amount of time describing what I call the problem of disparities in health and health status between racial and ethnic groups in the United States. I'd like to spend most of the time talking about how we understand the mechanisms for these disparities, with a particular focus on relationship dimensions in healthcare that may be linked to disparities. And then finally, we'll spend a little bit of time talking about interventions that I've worked on with my colleagues that are aimed at the improvement of race relationships as a strategy to overcome disparities, and then end with conclusions and implications. So many people may already know this, but for those of you who haven't been focused on this, you may be wondering, what are health disparities? Well, a health disparity population is a population where there's a significant disparity in the overall disease incidence, prevalence, morbidity, mortality, or survival rate in the population compared to the health status of the general population. And early in the 21st century, the Healthy People 2010 indicated that certain groups of individuals were considered to be part of health disparity populations. You can see that disparities occur by gender, race, ethnicity, income, disability, geographic location, or sexual orientation, and we're going to focus on race and ethnicity today. And what do we know about health disparities? Well, we've been studying this for over 100 years, and probably even more so in the last 30 years. We know that they are extensively documented. They exist for all the common population health indicators, including life expectancy at birth, infant mortality rates for the overall population, as well as sickness rates. And they seem to exist for ethnic minority groups relative to whites almost across the board for so many different indicators, although they may differ for specific diseases or specific subpopulations. We also know that health disparities result from complex interactions among multiple factors. And these factors are often differentially distributed across the population, across different population groups. These are biologic factors, cultural, socioeconomic, environmental, psychosocial, as well as health risk behaviors. And finally, access to care and quality of health care are all believed to interact and contribute to health disparities. I've highlighted access to health care and quality of health care because that's the topic of our lecture today. So what are health care disparities? We started out talking about disparities that exist in health and out in society, but what we came to know over the last decade or more is that, in fact, even within healthcare, there are disparities in care that exist. And the IOM report, Unequal Treatment, which many of you may be familiar with, was published back in 2003, and that report actually came out with the following definition. Healthcare disparities are differences in care that result not from differences in access or clinical appropriateness or patient preferences, but rather from discriminatory processes within the healthcare system, or from bias and prejudice, stereotyping, uncertainty, communication, and clinical decision-making problems between providers and patients. Now, I just want to clue you into the fact that this statement was made based on a lot of indirect evidence, because what the IOM report did was review decades of literature documenting that healthcare disparities were pervasive and could not be explained by differences in access and patient preferences or clinical appropriateness. In fact, what they found was that these differences in care existed across conditions, across populations of patients, existed in numerous care settings, across levels and types of care, all the way from the most simple, basic type of diagnostic test to the most complex type of procedure. And so we're thinking about things like just getting, for example, a pap smear in the doctor's office, or a blood test or a urine test or something like that, all the way to getting organ transplantation or getting a cardiovascular procedure or bypass surgery. The other thing that the IOM report found in its review was that if you think about how healthcare quality is conceptualized as having these different dimensions, including access, timeliness, effectiveness, safety, patient-centeredness, and equity, you saw that there were disparities between ethnic minority groups and Caucasian groups in healthcare. Around the same time that the IOM report came out, my colleagues and I were working on a model that would help us better understand what some of the potential mechanisms were for these disparities in healthcare, as well as maybe provide us with a framework for developing interventions. And what we found, this is a very complicated diagram, was that basically there are barriers in access to care that exist on the personal or family level for patients, as well as structural barriers within the healthcare system and financial barriers, and that all these barriers actually impact on the use of services, the type and setting of the service, and then once a patient gets into the healthcare system, there are several mediators of the care that they get, and that ultimately we care about all of these things because they do impact on health outcomes. The area that I want to focus on today is right in here where it says quality of providers. In the previous model of access to health care in America, there was not as much emphasis on particular qualities of providers. And
I'm going to pause right here and to just let you know, if you just tuned in, you're listening to the One Human Nation show. So what we're digging into is the disparity between people of color and whites in receiving health care. And believe it or not, it's kind of tied into this hot topic that's been trending this week as far as the bill that did not pass because, and I'm going to get to the title of this bill because I thought it was very interesting on what the name of it was. And to me, it ties very much directly into, I did a show, I think it was June 8th, you'd have to go back to that one, and it talks about the disparity in the high number of maternal and infant death rates among African Americans. And so what's interesting to me about this legislature that did not get passed through in the way it's structured, I don't know if you realize it was focused specifically on botched abortions. I know that sounds really terrible, but that's That's how this article that I'm kind of trying to get to here talked about it. So if we already have a disparity in how African Americans receive treatment, and how there is more of a target on abortion as opposed to other alternatives. Okay, here is the name of the act: the Born Alive Abortion Survivors Protection Act. And I know you may be thinking, well, Sandy, this is directly to all babies. It didn't matter what color. What I'm trying to get to is if there is a disparity, it is going to be on the more negative side for people of color, for babies of color, because that's what is systemic in our healthcare system. So what we're listening to through this lecture by a doctor that studied this, her name is Dr. Cooper, it's really diving into how access to care and the decisions that are being made may be, or actually not may be, according to the studies that they've done, is a negative towards people of color. And this particular lecture is digging into that into more detail. So let's continue to take a listen.
And some of the areas that we expanded upon in this model included the cultural competence of the provider, as well as their communication skills and their likelihood of either engaging in biased or stereotyping behaviors when interacting with patients who were from diverse groups or groups that were different from the providers themselves. And one of the reasons to focus on providers is basically because interactions between patients and providers, as well as other individuals in the healthcare system, are the central situation in which patients are diagnosed, given treatment recommendations, referred for lab tests or procedures, or referred to consultants. So in order to actually do anything in healthcare, you have to have some relationship with another person. And so we're going to focus on the quality of relationships between patients and providers. What do we know about this? Well, one of the reasons we know this is important, we sort of, it's intuitive to us that that would be important, but there had also been growing evidence that the quality of the patient-physician relationship is related to important outcomes. So outcomes such as the patient knowledge of their condition and recall of the information they were given, their adherence to recommended treatments, their satisfaction with their care, as well as to clinical outcomes. And in particular, pain reduction and depression resolution are the clinical outcomes for which we have the strongest evidence that the quality of relationships in healthcare matters. What little was known about was how these interactions, these relationships across racial and ethnic lines might be playing a role. So I thought I would share with you a couple of quotes that sort of really exemplify some of the issues we're talking about today. This is what one of the physicians in a study that I did had to say. He said, "I think it is more difficult to manage someone of a different culture. They may have different values. I often wonder if there's something else that either the patient hasn't told me or that I'm just not understanding." And he was talking about, this was a white primary care physician talking about his African American patient. And now I'll share with you two quotes from the patient perspective, one that is positive and one not so positive. So on the positive side of things, this African American woman with depression said, "The doctor I have now is great. He's nice and calm, and he asks a lot of questions. I think he's very, very sharp. I think whatever this guy tells me for the most part, if it sounds sensible, I'll give it a try." On the flip side of that, you can see where this African American man who didn't have such a great relationship with his physician said, "Do I believe this doctor? Do I trust that doctor? Are they just giving me medications just to throw them at me?" So you get to a point where you don't actually take the medication. Now, there are several dimensions of relationship that may have potential links to disparities in healthcare quality, but I've chosen to focus on 6 of them today. And they're very much interrelated. So we'll start out first by talking about communication. These are the behavioral actions through which all other relational features are observed. Second, partnership, which is a union that values the unique perspective, knowledge, and participation of each person. Concordance, which is shared identities between patients and clinicians, and this may be across visible dimensions such as race, gender, or age, and across less visible dimensions, so just things like beliefs, values, preferences. The fourth dimension that I'll talk about today is trust. This is the degree to which one believes that another person is competent, caring, responsible, and ethical, and will act in one's best interests. Respect, which is the recognition of each person's inherent value. It's an attitude of unconditional positive regard. And then finally, bias and stereotyping. These are preconceived judgments or opinions about someone or a group of people. We want to note that bias and stereotyping may be held by anyone, could be held by clinicians or patients. For the sake of this lecture, we're going to be talking about the influences of clinician bias on healthcare quality.
I'm going to pause right here. It's time for us to take a couple of station breaks, some announcements. So if you just tuned in, you're listening to the One Human Nation show, and we're talking specifically about the medical profession and unconscious bias, or implicit bias, whichever way you want to look at it. And it is also, to me, a direct connection to some of the bias that may be that's involved in our political system that we don't think about. And in some of the bills and things that we see going through, is there more going on than just what's attributed to one political party or to another political party? And, you know, the question that just resonates with me as an ongoing question is, how much further could we be along in our discussions and becoming one human nation if we all took a closer look, and maybe it should be a requirement for everyone serving in Congress or any political arena to see how do they test out on unconscious bias, you know, how they can look at themselves differently and maybe not even realize that they're making decisions based on something that they had not even taken into consideration. And so, I do want to make this clear that this is not only a white person issue or a black person issue. This is a people issue. One of the books that I'm reading currently that was brought to my attention kind of a couple of different times, and I kind of blew it off because I thought, oh, okay, I really don't. I don't need to read about that. That's really something for white people. And I think that's one of the silos we get into. We make these judgments. And when I mentioned the title of this book to someone I really respected that was African American, and she, spends a lot of time doing diversity work, she said, she told me, she said, until she read this particular book, she really didn't understand the white side of the equation. And I think that's what's important for us as a nation to start moving together, is we have to be able to look at the other side of the equation, look on the other side of the fence, but to be able to do that through lens that are not clouded one particular way. So the title of the book is Waking Up White and Finding Myself in the Story of Race. So this particular book, and I've just started reading it, and this person that wrote it, I'm going to get back to one of the part of the introduction that really, really kind of says a lot for this person that is writing this book. And she's going to get into, her childhood of being white in the story she heard. But, I like the way she says, no one alive today created this mess, but everyone alive today has the power to work on undoing it. And she goes on and she talks about racism crushes spirits, insights, divisiveness, and justifies the estrangement of entire groups of individuals who, like all humans coming to the world full of goodness, with a desire to connect and with boundless capacity to learn and grow. Unless adults understand racism, they will, as I did, this is the author and what she's talking about, unknowingly teach it to their children. And so it's I've just started reading it, but it's very fascinating. And when she gets to talking about the childhood in white, she quotes Frederick Douglass by saying, "A man's character always takes its hue, more or less, from the form and color of things about him." So let's take, just a quick little break just to make some announcement and hopefully you can stick through as we continue to delve into this subject, because it's kind of unsettling, and the experience that I'm even having going through the healthcare systems is, it's not where I feel like my team is biased, but there are moments like today where there is a total bafflement of, I'm not quite sure what to do next. Let's try this. And the attitude that you have going into it plays a huge part in that. And we're going to talk about that a little bit more. And Dr. Cooper in her lecture gets into that also. And that's a huge part of communication. So let's take a break and make a couple announcements, and we'll be back with the One Human Nation show.
This portion of WRUU-LP Savannah Soundings programming is made possible by listeners like you and Brighter Day Natural Foods. Brighter Day is celebrating its 40th year serving the Savannah community with produce, vitamins, and supplements, and a deli and juice bar. Brighter Day is located at 1102 Bull Street at the south end of Forsyth Park. More information available at 912-236-4703 or brighterdayfoods.com.
How many times have you heard WRUU's corporate underwriting message? If you remember it, then your potential customers remember your message as well. We are offering this space to connect corporate and institutional partners with our loyal and active listeners. Underwriting on WRUU is short, so listeners don't tune out. It's exclusive, so your message won't be lost in advertising clutter. And it supports Savannah's only community radio station. For a marketing package to increase your reach beyond traditional media, email underwriting@wruu.org.
The Neighborhood Improvement Association offers free tax preparation by IRS certified volunteers for low and moderate income residents at various locations in Chatham and surrounding counties. For more information, visit naicdc.org or call 912-447-5577.
This is WRUU-LP, Savannah, Georgia, 107.5 FM, WRUU.org. We are Savannah Soundings, community radio with global soul.
Welcome to the One Human Nation show. And if you just tuned in, we're taking a little deeper dive into listening to information about unconscious bias. And I talked about a book that I'm reading now entitled Waking Up White, and finding myself in the story of race. And this is from a perspective of a white female that, is sharing her story of going through a waking up process. And I thought it would be interesting after getting some reinforcement from an African American person of, until I read that book, I really did not understand why it's such an issue and why it's so difficult for many white people to kind of wake up to this reality. And I think it has a huge play in what we see in politics. It has a huge play into the medical profession, which I'm touching base on more today. But there's so many takeaways of what we're listening to in this lecture that I think that it goes across a lot of our systems in this country, including law enforcement, including our school systems. And until we really take a look at this topic of implicit bias and what it means to take our lens off and really look at what am I doing and what can I do to influence a different outcome. So we're going to continue to listen to this lecture from Dr. Cooper talking about solving the health disparities based on what they've discovered in this study that they did. And this is a lecture that's dated from May 2011.
So I'll start out by telling you somewhat of a story. It's just a journey of sort of my scientific inquiries in this area. I started out early on with a study that was called Race, Gender, and Partnership in the Doctor-Patient Relationship. And remembering that partnership is one of the important dimensions of relationship. And what I did was I conducted a telephone survey with my colleagues of adult attenders of primary care here in the Washington, D.C. metro area. And we were able to survey over 1,800 adults who had just been in to see their primary care physician. There were 65 of them in the last 2 weeks, and to ask them questions about the quality of care that they received. We were hypothesizing that race and gender concordance between the doctors and the patients would be related to an important measure of the quality of relationship that we called participatory decision making, or PDM style. Now, how do we measure partnership or participatory decision-making style? We used an instrument that was developed by Sherry Kaplan and colleagues, where patients were asked to respond to these 3 questions. If there were a choice between treatments, how often would this doctor ask you to help make the decision? How often does this doctor make an effort to give you some control over your treatment? And how often does this doctor ask you to take some of the responsibility for your treatment? Scale. So a higher score means that the doctor was more participatory. We found that ethnic minorities rated their visits with physicians overall as less participatory than white patients. That included African Americans as well as Hispanic and Asian primary care patients compared to white patients. And although there was only a 3 to 4 point difference between the minority group and the white group, it turns out that in a previous study that used this measure, a 4 point difference in this measure was related to a 10% increased likelihood that the patient would switch doctors in 1 year. We also found when we looked at race and gender concordance that patients who were in race concordant relationships rated their physicians, race discordant relationships rated their physicians as less participatory. There was a similar pattern for gender discordance, but it didn't achieve statistical significance. And this was true even after we adjusted for a number of different potential confounders, such as the patient's age, gender, marital status, health status, and their length of relationship with a physician. We then became interested in understanding what was going on in that black box of the doctor-patient encounter. Was it just that patients perceived that there was less partnership, or could it be true that the communication in the encounter actually differed? So we conducted another study, patient-centered communication, ratings of care and concordance of patient and physician race. We went to primary care practices in the Baltimore and Washington area, and we sought practices that delivered care to diverse patient groups. And we also sought practices in particular where physicians of different race and ethnic groups practiced within the same practice. We recruited 31 primary care physicians and over 250 of their adult patients. You can see 110 whites, 142 African Americans from 31 primary care physicians. They were in 15 urban primary care practices in the Baltimore, Washington area, many of which were federally qualified community health centers. Our main predictor variable we were interested in was the race concordance in the doctor-patient relationship, and we were interested in looking at outcomes that included communication behaviors as well as patient ratings of care. To measure communication, we used a coding scheme called the Rotor Interaction Analysis System, or the RIAS. This system is a well-validated way of measuring communication, has been used in numerous studies in primary care and other settings. What happens is we have coders who are trained to listen to audio recordings of visits and to classify every statement that's made by the doctor or the patient into one of 37 mutually exclusive and exhaustive categories. The categories may be considered to be content-oriented, affect-oriented, or process-oriented. For content-oriented statements, they may be either of a biomedical nature or of a psychosocial nature. And these statements may be related to gathering data, such as even asking questions, or they may be information-giving statements. The affect or rapport-building statements are more statements that are related to the emotional nature and the relationship-building piece. There's emotional talk, there's positive and negative talk. Positive talk is laughter and compliments that might be exchanged between the doctor and the patient. Negative talk, disagreements and criticisms. And then you have social chit-chat, which also falls into rapport building. And then the process-oriented statements are just orientation statements about the flow of the visit, for example, or facilitation statements where the doctor is actually trying to engage the patient in the decision-making related to his illness, or basically trying to make sure the patient understands and is following what's going on. So here are a few examples. So biomedical talk focuses on, for example, a biological measure like blood pressure, or the patient says, I was in the hospital last year for ulcers. For psychosocial talk, it's usually about family relationships, jobs, things that aren't specific to the disease, but so you can see here what the doctor might say and what the patient might say. Rapport building, again, empathy statements, statements of concern or worry, any kind of self-disclosure, statements of encouragement. And then partnership building, you can see the doctor might say to the patient, are you following me? And how does that sound to you after discussing a treatment plan? So we created some composite or summary communication measures from all of those individual categories of talk by the doctor or the patient. And these are the measures that had been in use in other communication studies, but hadn't been looked at across race and ethnicity. So verbal dominance, which is measured from the doctor perspective, the doctor is being verbally dominant if you measure all doctor talk and divide it by all patient talk, and you come up with a number that's greater than 1, that means the doctor was verbally dominant, versus if it's less than 1, then the patient was verbally dominant. Patient-centeredness is also another ratio. So it's created by adding up the psychosocial and emotional and partnership talk and all of the patient questions, and then dividing that by the biomedical and procedural talk. And so again, if patient-centeredness is greater than 1, that means the visit was oriented more towards the patient's agenda, whereas if it's less than 1, it means that it was oriented more towards the doctor's agenda. Then we have affect ratings. So the coders are actually also asked, in addition to coding the verbal content, to just listen to the voice tones of the doctor and the patient and to give overall ratings on voice tone quality at the end of listening to the tape. So what we do is we sum up the coder ratings of the doctor's assertiveness, interest, responsiveness, and empathy, subtract it from the coder rating of how hurried the doctor sounds. And we create a measure called the physician positive affect. And the patient positive affect is created similarly, except there's no rating for patient hurriedness because patients are never hurried, or almost never hurried. And then we have the visit duration, which is the length of the visit in minutes, and the speech speed, which is basically adding up all of the talk in the visit and dividing that by the length of the visit. So what did we find? We found that communication differs in the visits of African American and white patients. So physicians are verbally dominant with patients. You can see the verbal dominance ratio is greater than 1 for both white and black patients. However, physicians talk 50% more than white patients and 73% more than black patients. Similarly, the patient-centeredness ratio was somewhat higher for white patients than black patients. And patient and physician-positive affect were both higher in the visits of white patients than black patients. And this was true after adjusting for a number of different patient-level potential confounders, as well as physician-level variables that might have been differentially distributed across groups. These findings were true regardless of the race of the physician. When we looked at race concordance, however, we did find some interesting but other communication differences. So we found that patients in race discordant relationships had shorter visits with their physician. So we didn't actually find differences in the content of the visit, but more differences in the length of the visit, about 2 minutes shorter when there was a difference in race between the doctor and the patient. And also the patient was being rated lower in terms of positive affect in those visits. There was also a pattern whereby both the doctor and patient were speaking more rapidly in the race discordant visits. And we thought, at least at that time, that that was an indicator of anxiety or discomfort, and that this longer visit might indicate something positive. And it turned out that that is likely to be true in this particular case, because we found, similar to what we found in our earlier study, was that patients in race concordant relationships actually rated their visits better, and in race discordant visits rated their visits more poorly overall. The other relationship dimension that I wanted to examine in some of my work includes trust. And so this data, comes from a survey of Baltimore City residents, where we did a telephone survey asking patients about, basically we were asking them about willingness to engage in different types of treatments in medical care, and whether or not, and finding out what their levels of trust were. And what we found was that African Americans, when compared to whites in Baltimore, had less trust in physicians as well as in hospitals. And in particular, the African Americans had more concerns about their privacy being invaded and about being experimented on in a harmful way. And now this has been replicated in a number of different studies across the country, as well as national surveys. So this is not entirely surprising, but again, you can imagine a very critical aspect of relationship that could be contributing to disparities. We know that trust, for example, is associated with patient adherence and associated with positive outcomes.
If you just tuned in, you're listening to the One Human Nation show. We're taking a listen to the topic of health disparities and how that's connected to different things like communication. And it's resonating with me this week just because of, some of the things that are going through in our political system, and how communication is a key part of that. And when you watch certain things, it's the tone of voice, and a lot of times it's not what's said, it's what's not said. And so I do, because I see that this is going to need to be a two-part show, I've made a note of where I need to start this again next week to continue on this topic. I do want to run this quick clip that talks about the maternal morbidity rate, and why, some of this recent legislature that's coming through, is there a deeper look that we need to be taking stock of, instead of just kind of throwing stones and looking at it from totally or exclusively as political opinions depending on party affiliation. So let's listen to this information about mortality rates, and this is data. This show, this particular clip was a clip, I think, from 2018. And I'll make sure that I post that when I post the information about listening to the show and the recording of the show, of today's show.
We know maternal mortality is increasing in the United States, and we know that there are significant racial and ethnic disparities. We know African American moms in particular are dying at higher rates than white moms. In our study, we examined racial and ethnic disparities in severe maternal morbidity, which it is the need to undergo a life-saving procedure while you're in the hospital for delivery, and that affects about 60,000 women per year in the United States. We really wanted to understand disparities not only in maternal death, but in near misses for maternal death. And we found racial and ethnic disparities across all categories of minority women examined. And we found that the largest disparities existed among women with pre-existing chronic conditions, particularly among women with multiple chronic conditions. Some of the conditions we examined included asthma, hypertension, diabetes, substance use disorders, and we found higher rates of many of those conditions among racial and ethnic minority women. But in addition to that, among women who had certain conditions, still even greater disparities among racial and ethnic minority women. We also found that disparities in severe maternal morbidity were largely driven by blood transfusion, higher rates of blood transfusion among racial and ethnic minority women, which may be in part be driven by disparities in the treatment of postpartum hemorrhage. One gap in the literature is that care for certain conditions beyond pregnancy, either before you're pregnant or in that first year postpartum, involves looking at insurance coverage. And I think an important area for future work is to think about disparities in insurance coverage that affect reproductive age women beyond just their pregnancy. We know maternal mortality is increasing.
If you've just tuned in, you're listening to the One Human Nation show. There is one announcement that I do need to make, so let me do that real quick before I finish up the wrap-up of today's show.
WRUU 107.5 offers Savannah's most diverse radio programming. This evening from 7 to 8, Here It Is Tomorrow presents almost popular, no longer popular, and never was popular music. From 8 to 9, Crucial Rhythms features dance hall and reggae. From 9 to 10, Rigor Mortis brings you rockabilly, psychobilly, surf, and swing. And from 10 to 11, Route 66 highlights American rock as a window into the nation's culture. Find our full schedule at wruu.org.
And we are wrapping up on the One Human Nation show. Up next is going to be Troy Stoner with Sound Limits. One of the things I do want to touch base with you on in reference to some of the disparities that we don't think about, and that is we think about insurance as far as what insurance is going to pay for and what it's not going to pay for. But what you may not be aware of, and something that I've discovered, is it also depends on how the insurance company is approached on being asked for additional access to particular drug products. And what this means is if it's conveyed as part of the conversation that the patient has a positive attitude or, is positive about their treatments and is in relatively good health otherwise, sometimes that's going to have an influence on what decisions that insurance company is going to make. And so you may think everything is just cut and dried and yes and no, but you as the patient have a huge influence on what kind of care you're going to, or what kind of treatment you're going to receive based on the types of drugs that could be prescribed. And I'm going to put a pin mark in that and talk about that a little bit more as we conclude the show next week, talking about health disparities. And it's really kind of sharing what I've learned in my journey in the health issues that I'm dealing with, and the importance of not only the trust factor with your medical team, but in also how do you go about advocating for yourself in a way that it's not creating a conflict where you're creating a barrier between what you are trying to communicate and the kind of response, because you want a positive response from your medical team. Again, I hope you stay tuned for Troy Stoner with Sound Limits. So you get to listen to some music and decompress a little bit from this deep conversation. And we will continue it next week as we continue on this journey through race reconciliation, as it touches on different parts of our lives in ways that we may not even be thinking about intentionally, and we need to start intentionally thinking about it. Thanks for listening to the One Human Nation show, and I hope the rest of your week continues well.